Okay, so chapter 12 is called Schizophrenia Spectrum and Other Psychotic Disorders. So, first off, before we begin discussing schizophrenia, let's talk about what psychosis is. It is something that occurs when a person departs from reality. So, a person might be in a psychotic state when they experience what we call hallucinations or delusions. Hallucinations occur when a person has a sensory experience in the absence of sensory input. So it's when a person sees, smells, touches, tastes, hears something that's not really there. The primary hallucinations people experience are auditory, hearing things that aren't really there, and visual, seeing things that aren't really there. Sometimes people might also have some other sensory experiences. A delusion occurs when a person has a strong, inaccurate belief that persists even when there's evidence to the contrary. So a person is considered delusional when their thinking is unrealistic. So schizophrenia is a disorder that is pervasive and is characterized by experiencing psychosis and disrupted thoughts, emotions, and behaviors. So, when we think about the nature of schizophrenia and psychosis, let's do a little historical dive. First off, we had Kraepelin, who coined the term dementia praecox to describe those schizophrenic syndromes. And he looked at schizophrenia and some different categories of schizophrenia that could have been prevalent, such as catatonia, hebephrenia, and also paranoia. Then later we had Bleuler, who came around and introduced the first term schizophrenia, which we consider a split mind or splitting of the mind. And when it comes to the input that Kraepelin and Bleuler made into the field of psychology, their foundational views of schizophrenia are still very important to us because it helps us understand how this disorder starts and the course of the disorder over time. And we still use some of the terms they created. Psychotic behavior can refer only to hallucinations or delusions or the unusual behavior that accompanies them. So when it comes to DSM criteria, once again, I'm not going to go over all of the different criteria. I'm going to show it to you so that you'll know what they are. So here's the first page of criteria: having 2 or more of these symptoms in a 1-month period. Here's the second part of those criteria. And then there are that's the third part of the criteria for schizophrenia. Now let's get into a little bit about what a positive symptom is. A positive symptom occurs when there's active manifestation of abnormal behavior. So there's some type of distortion or exaggeration of normal behavior. So something is happening that we don't want to happen. Okay? So it's like a gross misrepresentation of reality. So delusions of grandeur and delusions of persecution are 2 of the most common delusions that a person might experience. So a delusion of grandeur happens when a person feels more important than they actually are. And a delusion of persecution happens when a person feels like somebody is after me or they're just trying to hurt me. A hallucination can involve a sensory event without environmental input. So again, can involve all of the senses: tasting something when they're not eating, having a skin sensation when not being touched, thinking things or bugs are crawling on you or inside of your skin. The most common type of hallucination, as I already mentioned, is an auditory hallucination. And there have been a lot of studies, such as neuroimaging studies, that tell us that the part of the brain that's most active during an auditory hallucination is Broca's area, which is involved in speech production. It's not involved in speech comprehension, but it's involved in speech production. And people who have Broca's aphasia have difficulty speaking properly. A negative symptom occurs when there's the absence or insufficiency of normal behavior. So there's something we need to see, but it's not there. So it could be something like avolition or apathy. So when a person doesn't appear to have any persistence or initiation or emotional expression. It could be allergia, which involves an absence of speech. It could be anhedonia, which is a lack of pleasure or indifference. It could also be affective flattening, which is a lack of emotional expression. When somebody is diagnosed with disorganized schizophrenia, um, and this cluster, here are some of the symptoms they might experience. They could have confused or absent abnormal speech, behavior, or emotions. They could also have cognitive slippage, where they engage in illogical or inherent speech. They could also have tangentiality, which is where they kind of go off on a tangent about things that may not make sense to others. They could also have loose associations when they engage in conversations that are in unrelated directions. Disorganized schizophrenia might also involve inappropriate emotional behaviors. It could involve a variety of unusual behaviors. Catatonia might occur when the person is completely still and they don't move. That could be considered a psychiatric spectrum disorder because of how specific it is. So when we think of the subtypes of schizophrenia, those don't really exist anymore. The DSM-5 kind of took those subtypes away. So now we know that schizophrenia can be divided into different subtypes based on the symptoms that are present, not paranoid, catatonic, residual, disorganized, and undifferentiated. Schizophreniform disorder is another schizophrenia spectrum disorder, and this disorder occurs when symptoms last between 1 and 6 months. If it's less than 6 months, we're going to generally think of it. If it's more than 6 months, we're generally going to think of it as schizophrenia. If it's between 1 and 6 months, it could be schizophreniform disorder. This is when a person experiences some of those psychotic symptoms for a short period of time, 1 to 6 months. A brief psychotic disorder would occur when those symptoms are present for less than a month. And both of those disorders are associated with a relatively good prognosis, relatively good functioning, and can continue to lead a normal life. Here are the DSM diagnostic criteria for schizophreniform disorder. Remember, it's going to be between 1 and 6 months. And there are the rest of those criteria. Here are the DSM criteria for a brief psychotic disorder as well. And there are the rest of those disorders, those criteria. Another schizophrenia spectrum disorder is schizoaffective disorder. And this occurs when a person has symptoms of schizophrenia, but then also have a mood episode, such as depression or mania. So these psychotic symptoms must also occur outside of a mood disturbance. The prognosis for people is similar to people with schizophrenia. People tend to not really get better on their own because they need to treat their symptoms of schizophrenia along with their mood disorder. Here are the DSM-5 diagnostic criteria for schizoaffective disorder. And next, we're going to talk about delusional disorders. Delusions occur when a person experiences thinking that's contrary to reality. A person with a delusional disorder might lack other positive and negative symptoms, and they might be delusional about any of these things you see listed. Again, grandiose delusions are typically the most common, but there could be any type of delusion a person experiences. It's extremely rare, though, that somebody has specific delusional disorder. It's usually schizophrenia where the delusional symptoms are present versus just specific delusional disorder. It does have a better prognosis than schizophrenia. And here are the diagnostic criteria for delusional disorder. It's going to be 1 month or longer, not meeting the criteria for schizophrenia. And here's some of those specifiers for those different types of delusions a person might experience. And for catatonia, this occurs when a person has unusual motor responses. They might be particularly immobile or agitated or have odd mannerisms. I've often seen catatonia where a person is completely still and they just don't move. It oftentimes tends to be severe. It also can be very rare. It may be present in psychotic disorders or disorganized, or diagnosed as a alone disorder. And it could include any of the specifiers you see down at the bottom: mutism, stupor. Psychotic disorders that are due to other causes, and this could be result of psychosis that's the result of substance use and medication use. And I will say that I have seen a number of clients who end up developing symptoms of schizophrenia after using drugs. And that's actually quite common. And it's just permanent symptoms of psychosis, symptoms of schizophrenia, and because the person took a hit of the wrong substance. Um, and of course, that can also happen with medication. Here are the DSM criteria for a substance or medication induced psychotic disorder. And here are the DSM criteria for psychotic disorder that's associated with another condition. So now let's take a look at a few of the statistics related to schizophrenia. First off, I want you to understand that schizophrenia only affects about 1% of the population. It's actually a very rare disorder, although people tend to think it's pretty prominent. Also, when it comes to how schizophrenia develops, it typically develops in early adulthood. I would say early 20s for males and early 30s for females. Although it can emerge at any time, there are some childhood cases of schizophrenia, but it tends to be quite rare that that actually happens, but it has happened. The course of schizophrenia is typically chronic. Most people are going to suffer with moderate to severe lifetime impairment. The life expectancy is slightly less than average. There is an increased risk of suicide, increased risk for accidents, and self care may be poorer. But I will say that when it comes to leading a normal life, I've had a number of clients with schizophrenia, and medication and understand the importance of always staying on medication is extremely important. And if someone with schizophrenia tends to take their medication consistently, they can lead a normal life. The problem is most people with schizophrenia will think they're better and they don't need to take it. Schizophrenia generally affects males and females equally. Females tend to have a better long-term prognosis. Remember, it's usually developed a little bit later in females, early 30s versus early 20s, because for males, they have a earlier onset. We know that some cultural factors could play a role. Sometimes, depending on cultures, symptoms might be there that people say that's just my crazy cousin so and so. But the rates of schizophrenia have been consistent through all cultures. There's also been some family studies. We know that there could be a genetic component to schizophrenia, but not those specific subtypes. Or the subtypes don't really exist anymore, but the specifics on what symptoms a person might experience. We know that there's an increased risk because there's been a lot of twin studies that show that schizophrenia has greater risk within families. And so if you look there at the chart, you can see that those monozygotic twins have more of a risk than other siblings. Once again, here are some of those research findings from those genetic research studies. Adoption studies have also played a role, so we know that there's a genetic component. So those monozygotic twins are going to be the ones that share the same DNA, and those zygotic twins, which are considered just regular, normal genetic siblings, the prevalence rate can be a little smaller. So we know that schizophrenia is also linked to multiple genes. Schizophrenia patients show reduced ability to track a moving object with their eyes. They also can have deficits when it comes to smooth pursuit eye movement. From a neurobiological standpoint, we know that the neurotransmitter dopamine tends to, there are higher instances of higher levels of dopamine in the brains of people who have schizophrenia. So drugs that are going to increase dopamine levels will result in schizophrenic-like behaviors, and drugs that are going to act as antagonists, which are going to reduce those dopamine receptors, are going to reduce those behaviors. We also know that enlarged ventricles and reduced tissue volume could tell us something about the brain functioning of individuals with schizophrenia. We know that there's less active frontal lobes, which we call hypofrontality, which is a major dopamine pathway. So it's probably impacting those levels of dopamine that's getting to the brain. And we also know that viral infections during early prenatal development have also been found to have a link with schizophrenia. It was often thought that going through the first trimester of pregnancy and developing a viral infection could, or influenza, something like that, could lead to schizophrenia. We also know that marijuana use can increase the risk for developing schizophrenia in at-risk individuals. Schizophrenia can reflect diffuse neurobiological deregulation, and there can be some structural and functional brain abnormalities. I will say there was a time when I worked with a lot of patients with schizophrenia, and marijuana usage was very high in that population, medical marijuana, for example, and in places where it was legal. And many of those clients, as clinicians, we were always concerned about the impact it was going to have, because we know we've got to see how this affects people. And I think there's a lot of research in that area as well. So when we start to think about some of the things that may cause schizophrenia, we know that stress may increase the risk of relapse. It could activate some type of underlying vulnerability. When it comes to the development of schizophrenia, we always think of what is the precipitating event, what is the thing that kind of triggers the onset of the disorder. We know that family interactions, having high expressed emotions, and things like that may also play a role. From a psychological standpoint, the diathesis stress model could play a role in the development of schizophrenia. Um, and when it comes to treating the disorder, antipsychotic medications are typically used. They're the first line of defense. They've been used since the 1950s. Once again, if people with schizophrenia take their medication, they can lead a normal life. The only downside to many of those medications are the side effects, because they can cause Parkinson-like symptoms. Also, something called tardive dyskinesia, which is kind of a twitching behavior. I don't know if you guys remember recently. I know that there have been some medications that have been found to cause enlarged breasts in men, and though those are often used to treat schizophrenia. So that's definitely a downside. But again, many people with schizophrenia are often non-compliant with the medication. So being able to find the medication that works best is the key for lifelong treatment of the disorder. From a psychosocial standpoint, having community care programs, teaching social and living skills, having behavioral and family therapy, vocational rehabilitation, all of those things can also be helpful for managing the disorder. But again, the best outcomes are typically with medication. From a psychosocial standpoint, having illness management and recovery, which engages patients and in an active participant role so that they can focus on settling and dealing with functional impairments, is important. Taking into account cultural considerations is also necessary, because from different cultures understand their disorders in different ways. And when we can normalize things, it can make it so that people are more likely to seek treatment. And using prevention, identifying at-risk children and intervening early on is best. So to summarize, schizophrenia has a spectrum of dysfunctions. They can often impact a person's cognitive, emotional, and behavioral domains. They can involve positive and negative and disorganized symptoms. The DSM-5 is going to document the range of those psychotic disorders. And there are several biopsychosocial variables that can be involved that can impact how the disorder is expressed and how we treat it. But oftentimes, successful treatment is rarely going to include a complete recovery. So there's a number of things, because this is something that's going to be lifelong, that have to be done to help a person manage their disorder. So I hope this has been helpful for you in understanding schizophrenia and other psychotic disorders.